It's great to see you all here, and great to see so many familiar faces and people that we're working with in the work that we do. I noticed a slight drop-off for this research session, and I appreciate that it is sort of late in the day, but all the same, it would be nice to give you an update of some of the stuff that our team's working on, and also then to introduce you to some great emerging researchers in the space in terms of new technologies, new approaches, new devices. So I think it's quite an interesting session coming up. First of all, I'd just like to acknowledge that we're here on Noongar Whadjuk Budja and pay my respects to elders past, present and emerging, and also just want to say thanks. I'm just here on behalf of my team today, but I have some great Aboriginal staff that I get the opportunity to work with and learn from, and I really feel like that's great for my growth and getting to share that wisdom they have about how to achieve better health in the community. So I just want to acknowledge that. I just called my talk what the topic of the session was. It's really just going through some of the stuff that's going on in this space, mainly around the work that our team is doing, but focusing a bit broader afield sometimes. But I'm going for the bird's eye view, and then Robin and Intan will give you a real detailed look at some emerging work that's going on. So, these are kind of the broad research areas I'm going to talk about today, and this is our team, or most of the team there, hanging out we got some, nice new shirts earlier this year, so we tried to get a nice photo all together. And this is the project that we are working from. We have a couple of platforms that we do our research from. This is the Charlie Wongan project. It's based in South Metropolitan Perth, and it's focused on Aboriginal children and early identification of ear disease and trying to find out new ways to better diagnose, better treat and provide better access to services in the local area. But we also obviously have programs that we do within the hospital as well. I'm not going to focus on that so much, but every child who gets referred to the PCH outpatients, if it's with a ear-related condition and they're from the metro area, then we offer them enrolment in some research studies which are quite similar to the work we're doing here. So as you know, waiting lists are a big problem, and that's one of the things we're trying to tackle. This is our community advisory group who we work very closely with in terms of what questions we want to ask, what are the problems in the community, how can we best address them together in partnership. And I think that one thing I've learned over the last 5 years is if you're going to go to all the effort of trying to develop a research project, trying to get something funded, you have to make sure it's something that people want and need in the community. And the only way you know what that is by working with them and learning from them, because they know more about all of this than you ever will. And I think we've gone on a really good journey with our community advisory group to the point now where the community members are becoming co-authors on publications, co-applicants on grants, co-presenting with us and the team, and I think it's really good. They're really shaping the sort of questions that get asked and how we approach the research that we do, so I'm really thankful for that. In terms of prevention of otitis media, this is an area where there is some emerging work going on. There has been it's probably been talked a little bit about today in terms of things that have previously been identified in sort of population-based studies in terms of the importance of keeping vaccinations up to date, potential protective benefit of breastfeeding for at least 4 to 6 months, and reducing passive smoking. All those things we kind of know a little bit about, but also they're kind of marginal. They can be marginal benefits, but it's about sort of a package of preventative measures. This is led by Sydney University, or Western Sydney University. They're trying to get a collaboration to do a national clinical trial of preventative measures and trying to see what the combined effect of adding in lots of prevention programs would be for ear health, but not just ear health, but upper respiratory tract infections in general. Sadly, getting federal funding for big studies that are nationwide is very difficult, and it's been put in for a couple of years now. It still hasn't got funded. You're competing against everything else, every other condition that's trying to get funded as well. But I think it's a hugely important piece of work that I'd love to see get up in the next few years. Some work that has been funded is early experimental work on using nasal probiotics in young infants to try and delay the onset of a first otitis media infection, which is very interesting work. They've obviously done a few things in mice, as they always tend to do, and really what they're moving to now is a first-in-humans trial, and this has been funded by the NHMRC. It's led by Leanne Kirkham's group at Telethon Kids. So that'll be really interesting. So when you do a first-in-humans trial, you do that in adults, and you're trying to see if there's a signal of effect, and then if there is, then they'll move through to try and do that in the target population, which will be, infants. So I think that'll really take about 3 to 5 years to mature as a research program and see the results of the first-in-human trials. But certainly they have seen a signal of effect in a mouse model, so they're hoping they'll see something in humans as well, and hopefully they have to check that it's safe and all that sort of stuff. But I think it's certainly an interesting area. And really, delaying that the onset of the first infection is quite key. That does tend to be linked with how many kids go on to get chronic disease, and obviously it will reduce the amount of time they spend with chronic effusion and hearing loss as well. So eliminating otitis media totally would be a very difficult task because there's lots of different pathogens that can cause it, but if you can chip away at some of them and delay the onset, that's going to have a positive impact down the road. And so that's primary prevention. There's also looking at improving the initial treatments that children get, so preventing those acute episodes of otitis media turning into chronic or recurrent ear disease. So that's pretty key, and that's more primary care based, which I'll talk about in a sec. Because I'm talking about prevention, I'm going to share some of the sort of hot off the press stats that we have not published just yet, but I just wanted to share with you because it's such an enlightened group of people on the ground who know what's going on. This is data from our prevalence study, which is a birth cohort of kids, Aboriginal children based in the South Metro area, and this is looking at the prevalence of otitis media at 2 months. Which is published at 39%, 6 months, which is also published, it's 52%. The data we're looking at now is the 12-month follow-up, where we found 65% of kids, Aboriginal kids, having otitis media. But critically, 45% have a hearing loss as well. And so Francis was talking, in his session there about the tympanometry, and sometimes you have the flat timps, but they don't have the hearing loss, and so it's okay, you can watch and wait a bit more. And I suppose this is just following on from that and just showing the really high incidence of hearing loss at 12 months. Now we need to unpack this a bit more because there are some kids who maybe had OM at 2 months but then don't have it at 12 months, and I was having a little chat to Marion earlier, there's 55% of kids who do have all right hearing, which is also good. So we need to try and take a strength-based approach as well, as like what factors contribute to the kids who have good hearing. Same, 65% have otitis media at 12 months, so 35% don't. So who doesn't have it? Why don't they have it? That sort of thing. So we're really this is just, like I say, we're just doing a first cut of the data at the moment, and we really still need to unpack it. But it certainly does show that in this first year of life, there's a high prevalence of disease, and there's also a high prevalence of hearing loss in this group. And the average hearing loss for the average hearing level for the cohort across everyone is 35 dB for the better ear, which is not great. So this comes to, because this is sort of a digital health conference as well, so we're trying to focus on that too. And certainly in our team, we're really moving to those digital tools, and we'll talk a bit more about that as we go along. And the way we go about it in the Charlie Wongan program is it's all about improving that diagnosis and providing a pathway to comprehensive care, so being linked up to ENT surgeons, whether that's through telehealth to the hospital or through having visiting ENTs come there. We try and use smartphone-based otoscopy and audiometry, which all goes into a central database, which I'll talk about in a little bit. And we've done some research on this, and I talked about this a few months ago when we met. So I'm trying not to go over things too much, but we still really like the finding that the quality of the video otoscopy we got, we compared images obtained by Aboriginal health workers, research assistants with limited training, nurses, audiologists and ENTs, and they were all all the same. There was no difference between who obtained the image and how well they could be rated at the other end. So it was kind of a really great demonstration that with a bit of training, a research assistant or Aboriginal health worker or audiologist got images of comparable quality to the ENTs on the day. So that was great. And so that's the approach we use now. But I'm still constantly surprised. Like we did a little public health. Not public health. They have the telethon weekend. Because I work at Telethon Kids, they do the telethon weekend. They got me to go along and check some ears, and we gave histories on all the kids, and pretty much everyone said their ears were fine. But we're still seeing ears like this for kids and parents who are saying that there's no problem with their ears or hearing. So we're still picking up, whilst we know that there's less discharging ears in the community now, which is great, particularly in metro areas. It's still there, it's still prevalent, and we still need to find better ways to capture it. And that's why, we've had a bit talked about the universal screening of infants and young children. That's why it's so critical, because there certainly are still these discharging ears, even in the city as well, coming through. We did a project as part of the telethon weekend, and that was looking at whether videos or images are better for videotoscopy, and we found that if you have the capacity in terms of your IT equipment, having a short video was easier for someone remotely to diagnose than an image, and that kind of makes sense, particularly with paediatrics. When you're relying on a single image alone, if the kid's moving or whatever, you can capture the canal wall rather than the drum, whereas if you've got a short 10-second video, you can kind of see the journey in, have a look around. And that's similar to the live telehealth programs we do. Like, it's always nice when you can get live otoscopy on the day, which Wheat Belt team are really good at. So, I think that, once again, it's kind of a common sense finding, but it's nice to just bring that research in and get that rigor into what we're doing, just so we know that what we're doing is based on the best evidence. Now, I'm not going to talk too much about this, because Robin will talk to you about this, but this also carries on from what Francis was saying. If you were in that session, he was saying about how 1 in 6 tympanograms are wrong, particularly the type Bs. So there is some emerging technology which is called Wideband Tympanometry or Wideband Absorbance, and so we're adding that into the work that we're doing in the community. So it's actually a module you can add on to your tympanometry, and it basically comes out like a 3D TIMP, and we're hoping to get a better characterization of what's going on with the eardrum, but Robin will tell you more about that. In terms of improving diagnosis, if you guys don't already have it, you should download the Otitis Media Guidelines app, because it's got, we spent 5 years going through all the best evidence, and where we couldn't find any evidence, we've tried to reach an expert consensus on what should be, on what diagnosis constitutes and what the treatment should be. I'll leave it at that, but download the app if you don't already have it. It won't. I was going to say it won't be the first time I mention it, but look, it's on the next slide as well. So in terms of treatment of otitis media, this is a really interesting space. A lot of people don't agree on what should be the best treatment, and when we did the clinical guidelines, a lot of the evidence isn't very good. It sounds crazy sometimes, because so many kids have this. You think it's all based on great evidence, but a lot of the evidence out there isn't great quality, and there are a lot of ongoing studies actually in Australia trying to improve the quality of our evidence. So for instance, for acute otitis media, there's the WATCH trial, which is on the East Coast. So that's looking at the benefit of antibiotics versus no antibiotics, basically, because all the infectious disease physicians are really stressed about antimicrobial resistance and things like that, and rightly so. The same thing for OME. So Intan will talk to you about her new device that they're developing, which will be really interesting. There's also health promotion programs, and there's also big questions over if you are going to give antibiotics, which antibiotics should you give? So there's some that require 2 doses per day for 2 weeks, and adherence to that sometimes isn't good. There's some antibiotics that just require 1 or 2 doses, but they maybe have more side effects. So it's not really, there isn't a standardized approach necessarily. Like, we have the guidelines, so look at them, but even that there are gaps in the evidence that we have. So there are ongoing efforts to fill in those gaps. CSOM, that's some of the work that I've been doing around looking at all the trials in the world that have been done, and same thing on that. There's not a lot of great evidence, but topical antibiotics do seem to be the most effective intervention. Steroids don't seem to have an effect when they're added. We still don't really know what the best combination of treatments would be. Some people give oral antibiotics along with the topical antibiotics, and that may have some additional benefit, but then you get more gastro upsets and things like that when you start adding in oral antibiotics too. So there is a trial done in the Northern Territory that has finished, but it hasn't reported the data yet, so we're kind of waiting for that. That was looking at various combination of antiseptics, antibiotics, and oral toileting as well. So what we did last year was looked at all the trials for CSOM, and it ended up adding up to over 7,000 patients who'd participated in trials, and we added them all together. But what we ended up was 35 different comparisons of interventions, and now there's some very clever people who I'm working with from ECU who add those all in together into this, they call it a network meta-analysis, which basically means that you can look at treatments that are indirectly linked. So instead of just looking at, antibiotics versus no antibiotics, they might have a different trial that did antibiotics versus oral toileting alone, and you can sort of go across the way. Anyway, it's very complicated. I don't know. It looks good though. It looks good. They sent me this globe to include, so I've done that, and I'm assured that it's very rigorous. But no, I think it will be interesting though. It's still. Really what we're wanting to do is get to that point where we can actually start implementing some clinical trials locally to identify the best treatments. What we're doing first is trying to make sure that we're looking at the most important questions, so that we're not just starting trials that aren't going to answer the best questions. And this, just following on, this is a relatively new piece of work that we're doing, which we're really excited about, which is working with our Aboriginal Community Advisory Group to basically redesign the outcome measures that we use for people who participate in research and clinical trials. So a very popular quality of life survey is called the OM6, and this is it here, and it doesn't look very nice, and it's quite hard to read, and it's quite hard to fill out. And we showed that to our advisory group, and they were like, no, we're not using that. So, which is great. And so they've reworded the questions, they've redesigned a questionnaire, and we're just looking to evaluate that now to see if it gets comparable results. And then we're hoping to just, use that one on the right there in all our work going forward. And we're planning to do that with basically any outcome measure that we want to bring in, because there's these great ones that have been standardized internationally, translated into all these different languages and enable you to compare what's happening in your community to lots of other communities throughout the world, but they're not always appropriate for the families we're working with. So we're just trying to get that right balance of being able to compare to different regions across Australia and across the world, but also making it approachable for the families we work with. And the big thing that the Community Advisory Group wanted was they wanted it to all be digital. They wanted to be able to get all the questionnaires on their smartphone, fill them in, and then send them off to us so they can do that before their appointment. So I think getting that feedback from the community that they don't always want the paper forms, they want to just do it when they want to do it, send it off to you. I thought that was really cool, and particularly as we're moving to a lot more of our assessments being based on smartphones or tablets or whatever, I think that's quite a nice fit. Which brings me to, digitising clinical research. So you have this beautiful audiometer here, which we still have a couple of in our team, and we love very much. When you started off as an audiologist, you basically had to be an electrical engineer, and it looks like that could electrocute you. And this is a nice, bloodletting. So, that's the past, and now we're moving into the future. So, art is still art, audiology is still audiology, but there's modern, and that's good too. So I think it's all about, change. I'm an audiologist. We're creatures of habit. We like the kit we have, but I think there's a great push to get this new kit going, which, you know, everything gets stored in the cloud. It's easy to integrate into databases. It's much easier to keep track of everything. And I say that, like, you know, in the hospital, everything's still on paper. So, like, you know, I'm in a glass house. But certainly from our research side of things, we're trying to really digitise all the data we collect. And it's going quite well. You know, once people get used to it, it's going quite well. And Redcap. That's the symbol. That seems to be what everyone's doing now. All our data goes through Redcap. And I think, Peter, have the hospitals signed up to Redcap yet? Yeah.
Everybody Health has?
Yeah.
So Redcap is an improved database, so it can connect with, in theory, you should be allowed to connect it with patient management systems, so like WebPads. So you, in theory, you can automatically download the details from WebPads onto your registry or database.
Yeah.
So it is being used.
Yeah.
And can send PDFs back into, certainly WASNet, but I presume communicated as well that was being used.
So I think that's it. So, you know, certainly the future is going to be all digital platforms. So we have a Redcap database for our hospital work. We have a Redcap database for our Jali-Wongan work, and, you know, they're collecting similar outcomes, and we'll be able to talk to each other if we want to do that at some point. And I think, you know, with Marion as well, what you were talking about earlier, I think, you know, we need to be standardising the way we record some of the information, even if we can't integrate it all yet, having a way that we're all recording standardised information, so that if there becomes a point we can connect it all up, it would be great to be able to do that. Yeah, and everything's getting PC-based and smartphone-based, which is really great for these systems because you can upload it all. And you know, when we go and have an MDT meeting with the ENTs, you know, we can download all the patient information, put it, you know, because then there's still paper at the hospital, but put it in a nice little file for them, download it, and then upload it again later on. That's it from me. Like I say, really just trying to give you a bird's eye picture about what we're doing, how we're trying to digitise some of the work we do, and some of the other emerging areas in this space. And as you can see, I have a lot of people to thank. So if your name's not on there or your group's not on there, it should be. So let me know. And yeah, that's it from me. Thanks very much. Any questions before I introduce Robin?
Not a question, it's just you've got Australian hearing, we're now hearing Australia.
Yeah, that's good. That's good feedback. I'll swatch them over. Yeah. Cool. Okay. Well then, catch me at the end if you have any other questions. And without further ado, I'll introduce Dr. Robin Choi, who is a lecturer in audiology at UWA and one of the coordinators of the audiology program there, and also an honorary research associate at Telethon Kids. So welcome, Robin.
Oh, okay, cool. Technology, I should be more familiar with it. Thank you, Chris. So as Chris said, my name is Robin. I'm a lecturer in audiology at UWA. I'm also a co-clinical program coordinator with Helen Goulios, which a lot of you may or may not know. Before I start my talk, I'd like to acknowledge and pay respects to the traditional custodian of the land upon which we meet, the Whadjuk Noongar people, and acknowledge and pay respects to the elders of this land, both past and present. So today what I'll be talking about is a relatively new and novel tool called Wideband Absorbance or Wideband Tympanometry. Some of you may or may not have heard of it. It's been around for around 10 years in terms of research space, but in a clinical space, this hasn't gained traction yet. So today what I'll be talking about is how it works. Can it actually detect conductive conditions much better than our tympanometry, what we use normally in current clinical setting? And is it feasible to be used in a clinical sense? So as you know, Australia has a fantastic neonatal hearing screening program. We pick up most of the kids at birth with those with hearing loss. But as we all know, unfortunately, not every child gets picked up, simply because some of them are not born in hospitals. Others have acquired hearing loss within 6 to 12 months of their birth. And some other kids just have a congenital mild hearing loss that are just not picked up. So school hearing screening programs are really important for that, especially school entry. And what research have shown so far is that at school entry, around 12 to 19% of children fail hearing screening, which is quite a lot given that, we would hope most kids have been picked up by this point. And of those who fail, around 50 to 80% of children are found to have conductive hearing loss of mild to moderate degree, which is not surprising given that a lot of children do have otitis media, runny nose, etc., etc. Now, unfortunately, currently there are no universal hearing screening protocols in Australia. So hearing screening programs are available widely, not just in WA, but in other states like Queensland. What are states in here? Other states, yeah, the important ones, right? But there's no universal hearing screening protocols. So the most commonly used one currently are pure-tone audiometry screening, as you know, your 226 conventional tympanometry, and in some cases, transgenic acoustic emissions, but unfortunately, all these tests have limitations. Oh, why did I do that? Oops. In particular, tympanometry is an indispensable tool to pick up conductive hearing loss. As you know, we can, using TIMS, we can either get type A's, type B's, or type C's. And TIMS are great because it's simple. It gives us a nice graph that all of us are very familiar of. Unfortunately, type B doesn't give us anything else other than blocked middle ear. What does it mean? It could be otitis media, it could be a cholesteatoma, it could be really anything. Now, there's a new tool called Wideband Absorbance that, as I said, has been around for a little while, that has been found to be a useful tool to detect conductive conditions in children. So here at the bottom left, this doesn't have a pointer, the bottom left shows our normal tympanometry, as we are all familiar with. The bottom right shows the absorbance graph. So essentially they look very similar, but it gives us more resolution and more detail. So what is wideband absorbance, you might ask? Well, instead of a single frequency we use, like in tympanometry, we use a wideband click from 220 Hz to 8,000 Hz per ear, and we're looking at how much energy is being absorbed into the ear. So if the ear is nice and clear, we expect very little energy to be absorbed because some energy leaks out. But if the ear is blocked, obviously because of the blockage, the sound will be bouncing off. So you'll be able to detect more sound being bounced off. And wideband absorbance is good because A, is shorter. Tympanometry on average takes around 8 seconds. This takes around 2 to 3 seconds. And I know you might go, but it's only 5 seconds, Robin. But when you've got a screaming kid in front of you, you don't want to waste time, right? It also doesn't require pressurization like we do in tympanometry. So the big thing with tympanometry with young children, as you all may know, is it requires pressurization. And if you have sore ears, that really hurts, right? And this technology, we don't need pressurization. It's also insensitive to probe location, so you don't need to put it insert it very deep. As long as it's sitting in the ear canal, it can measure the amount of sound energy coming back. And unlike tympanometry that only gives you 3 classification, it gives you way more information, so we can differentiate between different types of middle ear pathology. Oh my God, I'm sorry, I'm not very good at PowerPoints. So WBA can differentiate between things like otitis media with effusion, otosclerosis, perforation, articular change discontinuity, and cholesteatoma. Now, normally, again, with tympanometry, it will just give you type B or type BH, but with wideband absorbance, it will give you a different graph. So this is what a normal wideband graph looks like. So this child has a very good middle ear, everything's nice and clear, eardrum's moving well, there's nothing behind the eardrum. It looks very similar to your tympanometry, but this time on the bottom hand side, you can see a different frequency. So it's looking at how much sound is being absorbed at each frequency, and as expected, we expect most of the sound energy to be absorbed between 1 and 4, which is a speech spectrum. Now, what happens if a child has sore ears? So if a child has otitis media with effusion or patent grommet, again, we get type B. Here, we can actually differentiate between the two. So as you can see, the graph looks quite different. Perforation, another thing we see a lot in young children. It's something, as you may know, is quite hard to see, especially if they're wiggling around and they don't want you to look at the ears. And again, tympanometry gives you type BH, a big ear canal volume. With wideband tympanometry, you can specify, or you can tell as much as possible whereabouts the perforation is. So if you have pinhole perforation, it's very different from anterior perforation to central perforation, and so on. So as you can see, it's quite useful, and it gives you more resolution in terms of the data. So what I did, or myself and my team did, is we basically went out and tested a whole bucket-load of school-age kids, and we asked 2 questions. Can we use this new technology called WBA, Wideband Absorbance, as a mass screening tool in school? And is it accurate, or is it more accurate than tympanometry in detecting conductive conditions of school children? So we used a cross-sectional and single measures design. We had around 120 school-age kids, and they were a little bit older than what we usually expect, so they were grade 3s and 4s, so the age range between 8 to 10 years old. And I am from UQ, so I only moved here just before COVID, so this data is from Brisbane. But we are working at the moment with Chris to collect data for WA kids, so hopefully next year we'll give you some more information. So these kids were selected from 5 primary schools in Brisbane. So because wideband absorbance is such a new test, we had to have some reference tests or gold standard tests to compare the results with. So we use otoscopy, pure tone screening, your 226 conventional tympanometry, and autoacoustic emissions to compare the results with. So these are the criteria. So a child was deemed to have normal hearing and normal middle ear conditions if they had clear otoscopy, so there's no wax impacted or anything like that, or Lego blocks or whatever they put in these days. Pure tone screening, they had to pass a 20 dB HL at 5, 1, 2, and 4. 226 tympanometry, we said they passed if they type A, AS, or AD. And the TOAs, they had to have signal to noise ratio at 3 dB or more at 3 or more frequencies. Then what we did was, after we conducted all these tests, before they went off back to the class, we performed wideband absorbance. So there you can see my student and a very good child sitting nice and still doing the wideband absorbance test. So again, what we did was we deemed a wideband absorbance result to be normal if the child passed all the tests, so tympanometry, your pure tone, and your RAEs. So, some results. What we did was, initially we looked at how many kids passed and failed each test in each year. So as you can see, as expected, most children passed most of the tests, which is great. And that's to be expected because these kids are older than 7 years old. As you all know, we expect a lot of children between 5 and 7 to have otitis media with effusion and a lot of sore ears. And because these kids were 8 years old and above, we expect them to have less of these issues. But consistent with the literature, we still had 12 to 16% of children failing these tests. Okay. What we did do is then went and ran a whole lot of statistical analysis to see if there's a difference in wideband absorbance between kids who had everything normal and kids who had who failed TEEPs and et cetera, et cetera. So here you can see the graph. So the green is the kids with conductive conditions, and the blue is the kids with normal conditions. And as you can see, there was quite a bit of a difference. So there was less energy being absorbed in the middle ear, which meant there was more fluid or something else going on in the middle ear in these kids. What we also found, What we also found was that the most significant differences were between 800 and 1,600 hertz. This is a massive table. I'm very sorry. I didn't know how else to present the data, but essentially what we then did was we ran a what we call ROC analysis, which is essentially looking at the test's ability to correctly diagnose kids with a condition and kids without a condition. And using this test, what we found was that essentially WBA had higher accuracy, predictive accuracy, than conventional tympanometry, and 1,600 hertz was the best frequency to see if a child had conductive hearing loss or not. So then we zoomed into that particular frequency at 1,600 hertz, and what we found was, compared to a reference line, so reference line meaning tympanometry, pure tone, and your TOE results, which is a green diagonal line, the wideband tympanometry had better accuracy, which is shown by the blue line. So if the blue line is closer to the one on the top left-hand corner, that means that the test is perfect. Obviously, no test is going to be perfect, but compared to the green, which is a reference test, the WBA performed much better. So what does this all mean? Can we use WBA as a screening device? The short answer is yes. Why? Because it's quick. It literally takes 5 to 6 seconds per ear if a kid's sitting really still. If you're really experienced, 2 seconds. And it doesn't cause discomfort because you're not pressurizing. You don't have to, push it into the ear. So it's quite safe. And children often like to see the graphs as well, which is nice. And on top of that, unlike your pure tone screening and your TOA results that are affected by background noise, the WBA results are not affected by background noise, which means this test might be more effective in detecting subtle conductive conditions that we can't often detect in schools. Now, this study only showed 77% accuracy compared to tympanometry, which is considered to be fair prediction. And this is probably because of smaller sample size, but other studies in Queensland have shown high accuracy up to 98%. So, in conclusion, WBA probably is an effective and feasible tool in detecting conductive hearing loss in school-aged kids compared to reference tests, especially tympanometry. We obviously have limitations, so the OA results are probably affected by ambient noise at school. We did make sure that ambient noise stayed around 35 to 40 dBA, but unfortunately, as we all know, schools can go up and down depending on, what activities they're doing, especially if they're swimming. They all run half naked, which is not fun. We also had a relatively small sample size compared to other studies, so hopefully with more funding and more data collection, we can improve the accuracy as well. And WBA gives you way more information than what I've looked at. I've only looked at the ambient pressure data, but there's other measures that you can look at, like admittance, phase angle, the resonant frequency of the ear canal, and that can, again, provide additional information to improve the diagnostic accuracy and to differential diagnose different mid-ear pathologies. So, in conclusion, everyone should be using WBA. I think it's a great tool. Unfortunately, it is very new, and that means a lot of clinicians will have to be trained. But I think with time, a lot of you hopefully will be trained, and we can hopefully add this to test battery. And this is because it's just more accurate, and it also gives you way more information as well. Any questions? Oh dear. I think you're first.
Yeah. I just want to know, thank you, the wideband or the WBA, so is that a separate machine or is that on our, yeah?
So, you know the Titan machine? I have a photo somewhere. Maybe not.
The one you were on that.
Was I? There, yeah. So you know the Titan, the thingy?
Okay.
Yeah, so it's basically it's basically a module that you can add on. I think the issue is a cost, because I think it costs around 10 or 20, right? Or something, I can't remember. Yeah. So it's an additional model you have to add on. But yeah, once you add it on, then you can use it.
Is that to all brands of Timps or just?
I think it's just, at the moment, it's just into acoustics and some other one that we don't use in Australia.
Yeah. So you have it on a laptop?
Yeah. So unlike the normal Timps that you would use with that Titan device, you have to have a laptop because it's like a research module thing. So yeah.
Fantastic study, congratulations.
Thank you.
You covered my first question, so thanks. Second question, just about the interpretation of the result.
Yes.
You need an audiologist or a clinician to do that, or is there an AI platform or algorithm built into that calls it for you?
At the moment, it's audiologists, but Chris and I are working on it. I didn't present it today because it's very preliminary. But this year we have dabbled into machine learning as well, simply because the graph, if you look at those graphs, I've spoken to audiologists and they're like, look, Robin, I don't have time. I've got 40, 50 kids waiting in the waiting room. I don't have time to go, wow, that's a pinhole perforation. They're like, we don't care. So they're like, can you develop something that we can basically look at something, they go, oh, this is probably pinhole perforation. Then we go, look, oh, it's cool. So yes, so we have started that work, and what we found was, yes, AI is able to do it. And it is, again, way more accurate, but we need more data. The data scientist was saying you need 20,000 kids. I was like, I don't have 20,000 kids. I can't produce them quick enough, so, Yes.
Robin, it's great to see that this is now beginning to be clinically available. I'm just wondering if you've read any of the literature in terms of predictive value with the type C tympanograms, where you're trying to predict, is this negative pressure going to become a otitis media, or is this a child that we can discharge?
That is a good question. I think most of the research has just been looking at type Bs and OMEs, but that is a good question actually, because you are right. A lot of the time we look at type Cs before we look at type Bs. Yeah. The good thing about WBA is that you, depending on how negative the pressure is, the absorbance value changes. So, if I didn't put it here, I'm so sorry. But with kids with mild eustachian tube dysfunction, what you'll see is this graph looks exactly the same, but with a dip at around 1.5. As it gets more and more negative, the whole absorbance value drops, simply because it fills up. Do you know what I mean? So that's one way I suppose you could use it clinically and go, well, you know, if you measured Johnny's Wideband absorbance a week ago and it was completely normal but just a dip, and a week later everything's down, you go, yeah, you're probably going to have OME, let's do something about it. So, but yeah, I don't think literature specifically looked at just that condition, but that's great.
Probably a related question to that, in terms of the type B,
Yep.
is the idea to be able to, I guess, differentiate between, say, like a serous effusion to
Yes.
more of the really kind of, you know,
Yes.
glue-like effusion. So potentially those ones that really need to kind of get to, like it's never going to come out, potentially.
Yeah, so again, I couldn't, because I thought it was 10 minutes, I didn't fit everything in. I'm sorry, but I just finished the exams and marking. But essentially with WBA, what the literature has shown is you can actually differentiate between how full the ear is. So, you know, you can, you know, depending on how you say half full versus full, completely full to only quarter full, the absorbance value changes, which is fantastic, because then audiologists or even, you know, nurse practitioners can look at it and go, oh, that's changing, let's do something about it. You know what I mean?
Awesome.
Cool.
Thanks, Rob.
Perfect.
Wonderful. Yeah, no, I think it's great to hear about these emerging technologies. I think it's really good, Robin, and yeah, great work going on in that space. Next, I'd like to introduce Intan Oldakowski, and she's a biomedical engineer at UWA Curtin and co-director of Perth Biodesign. So she's going to talk to us about some emerging technologies for treatment of OME. So welcome, Intan.
Thank you so much, Chris, for this opportunity to be able to present to you today. I feel really privileged to be able to stand here in front of you. So my background is biomedical engineer, and so I'm very actually quite new to the ear health space, and so really it's been inspiring to listen to everyone's presentation today. And I hope that you know, our goal for the device that we're trying to develop is really to be able to try and fit in and be another tool in your toolkit to be able to help with the management of this chronic disease. But yes, I really thank you again, Chris, for inviting me to present to you all today. It's been fantastic. And so I'd also like to start to acknowledge the country that I'm standing here today, and really recognise and continue connection, pay respect to the elders past, present and emerging. So obviously we've heard about this condition a lot today, obviously extremely prevalent, and it's really around that, you know, the fluid build-up, creating hearing loss, and ultimately developmental delay. And our goal really is to try and come in at an early stage to sort of prevent this disease to become chronic. And again, you know, you all have lived experience around this sort of transgeneration cycle of the ear disease, you know, all the problems that can be associated long-term with this disease. And so we really, again, want to kind of start at the beginning. And I've got sort of Dr. Kelvin Kong's quote here, not knowing actually that he was going to be a keynote speaker, but obviously really just highlighting how prevalent it is in the Indigenous community, and there is that really significant downstream effect of this ear condition. Just talking about the cycle of care, obviously there's been some fantastic work around improving the management of this condition within the community and also in the city. And really what we want to, with our device, is to come in once the children have been screened and it's picked up, rather than them being lost to the system. If we can provide this non-invasive treatment at that watchful waiting period, where most parents are really eager to do something about the particular condition, and hopefully we can sort of tackle there. And hopefully, obviously, there's been a lot of talk about the really long waiting list in WA. Obviously, for some children, that's just unacceptable. So if you can imagine, to be able to treat some of them at a much earlier stage, to be able to free up the waiting list for those that really need the surgery. So basically, I'd like to introduce you to the EarBuddy. It's a sophisticated medical device, I guess disguised as a sippy cup, that's targeted for young children around 2 to 5 years of age. And the idea is that it can be used at home, in the community level. It has an LED light that can show when treatment success has occurred, and it's got an accompanying app that you can sort of look at to be able to see whether the treatment has occurred. And so how it works is when the child drinks from the cup, essentially it closes the soft palate, and actually creating a system in that nasal pressurization. The device then detects when that happens, when that soft palate closes, and the pressurization, so it will create a gentle puff of air that's controlled to make sure that it's not uncomfortable for the child, into this sort of nasal cavity around here. And what that does is actually inflates open the eustachian tube that connects the nose into the middle ear. And the idea is that if we can open that eustachian tube and the device can get it to a pressure that is enough to open that eustachian tube, but without getting too high so that the child finds it uncomfortable, then we can actually, hopefully, with repeated treatment, drain the effusion or some of the effusion into the nasal cavity. Obviously, Dr. Lanigan also talked a lot about that really, really high negative middle ear pressure. And the idea is that if we can sort of naturally open the eustachian tube, we can equalize the pressure into the middle ear and hopefully alleviate that really high negative middle ear pressure that can lead to cholestoma and all the really severe conditions that we really want to prevent. And hopefully with sort of daily treatment and more prolonged treatment, we can actually shift some of the effusion and really prevent that glue ear and ultimately prevent surgery for the child. We're also hopeful that there is the potential to also create an app together with the device. The device itself can sort of work on its own without the app, and it can provide that sort of detection mechanism to say that the treatment has been successful. But we can also potentially have a tracking for the app to sort of help with healthcare professionals and also the parent for gamification and trying to encourage the child to actually do the treatment. We've been really fortunate to be able to have EarBuzz Foundation, collaborate with EarBuzz Foundation for our sort of really preliminary clinical trial in an acute setting. We've been working with them, and we've been recruiting children aged between 1 to 7 years old with either a type C, so that high negative middle ear pressure, or a type B tympanogram, so that flat pressure, potentially there's effusion behind the middle ear. What we conduct is basically around a 5-minute treatment session with the EarBuddy device, including drinking a cup of water. So basically, we sit with them, with the child, we ask them, can you please drink from the sippy cup? We'll turn on the device, and then we just sort of help them with using the device. So the older children, so say 4 up, they're basically able to do it without sort of any, hands-on help from us, and the 2 to 3 year old, as long as we can kind of help them stabilize the head, help them drink and hold the cup, they've been able to do it. And what we're trying to measure is really that intranasal pressure analysis during the therapy. So using the app that we've developed for the clinical trial, we can see the amount of pressure that's actually in the nose, and to see whether we think that the eustachian tube has actually opened. And we've set that at 0.4 psi based on the literatures of the amount of pressure it takes to open the eustachian tube, and that's quite low. We also do tympanometry before the treatment, do the treatment, then after the treatment, to see whether we've been able to, sort of resolve any type C or B. So far, we've recruited 18 patients. Average age is 3.14 years old, and our youngest child was 1 year, 9 months, and our oldest was 5 years old in this cohort. So the acute, I guess the results been really, really promising. Basically, we've had 100% of the children that we were able to recruit into the study able to achieve that EarBuddy target intranasal pressure of that 0.4 psi. So we're sort of fairly confident that we were able to open their eustachian tube in a single treatment session. And we've been able to basically an average of around 3.67 successful treatments per session. So essentially, the eustachian tube is being opened, more than 3 times within that single cup, drinking that 5-minute treatment. And so what we found is that 90% of the ears that had a type C, we were able to resolve to type A. So essentially, there was negative middle ear pressure, they drank the cup, and then we temped them again, and it's now equalized, and that negative middle ear pressure is no longer there. So which is really, really exciting for us. So basically, we're able to demonstrate that we are able to open the eustachian tube during that single treatment session. What was really surprising is that we were able to shift some of the type B ears, which means that the ears had some effusion in the middle ear. We didn't think that we'd be able to do that after a single treatment, after that kind of 5-minute session. But 33% of ears, or almost a third of the ears, we were able to change from that effusion type B to a type C in 12.5%. So still negative middle ear pressure, so there's still probably some fluid swirling in there, but we're not able to shift within that time before the child sort of goes, I don't want to drink anymore. But in 20% of the time, we were able to resolve that type A. So what that suggests is that there was some effusion in there, but that's been drained during that single treatment session. So overall, there was a 66.7% of children demonstrating acute clinical improvement within that sort of treatment, which is really, really exciting for us. So hopefully we can continue the development and refine this and get this data better. So really what we see the benefit for the patients and the carers, and echoing everything that's been said today, really want to get earlier treatment to minimise developmental delay. That kind of 2-3 year wait time is just not acceptable when a 2-year-old's coming in not able to speak 3, 4, 5-year-olds. So if we can kind of come in at that really early stage and potentially try and treat them at that stage to try and basically let them hear again to that minimise developmental, that would be fantastic. It's a home-use device suitable for regional and remote communities. So the device can be basically sit at a community, or it can actually be taken home by the parents during, if they're detected with a type C or a type B, they might use it for a month, and hopefully it can resolve the the ear condition, and then it can be returned. Or there are lots of different models that we can look at in terms of actually implementing this. But the main the main advantage is that it can be used at home and in the community rather than the patients having to come into the city. It's non-invasive. Of course, surgery is great to be able to resolve the condition, but there are complications. There's children's trauma, there's travel that needs to be done. The problem does tend to recur in a certain percentage of the children, which means that they have to do it over and over again. So this is to try and, stop that in certain percentage of the population. Benefit for the health system, of course, better patient outcomes, reduce surgery wait list, and hopefully if we're able to detect, potentially with Dr. Robbins, the wideband tympanometry, if we're able to see if some of the children have maybe the serous effusion, we can actually sort of treat them straight away and then leave that surgery for the children that have the really kind of glue-like effusion and actually get them to be treated as quickly as possible. So to be able to try and reduce that surgery wait list. Also reduce healthcare costs by focusing on prevention. And obviously, Dr. Angus Turner has already demonstrated that, focusing on prevention and kind of that management can really sort of improve and reduce cost. And again, suitable for deployment in community, ensuring equitable access for everyone, not only people, children in city area. So what's next for us? So this is really, really early, I guess sort of fairly early stage. This is kind of the first clinical trials that we've conducted with this device. We still need to refine it to improve usability and reliability in especially young children. We really want for the device to work every time for the 2 to 5 year old age group. That where the disease is really prevalent, and often that's when it gets picked up. So we're still trying to refine it, make sure it doesn't go into error mode and all this sort of stuff. So there's a little bit of still device refinement that we need to do. And because we know how how kind young children are with these devices, so we have to make sure that it's super robust. And really want to enter into a larger scale clinical trial to gather efficacy data. Been fortunate to have received WA Department of Health Child Health Research Fund to conduct a larger scale clinical trial. And so we're definitely we're going into that part for the next 2 years, and we've actually just going through the application to WAHEC to try and get ethics application to be able to trial the device in Indigenous children. So we're hopeful that we can get through that in the next few months. We then, currently we're sort of doing prototyping and potentially manufacturing of the EarBuddy devices with WA-based partner, Atama Innovation. So hopefully we can, create it locally for, our local population. And eventually the aim is to get TGA regulatory approval and then planning for implementation. But really today, obviously really honoured to be able to present today, and hopefully I can get really looking for some feedback of what your thoughts are around the device, things that we can improve, because we are still in this development stage, so we are wanting to make sure that we engage with the community and understand what your needs are to make sure that we can actually incorporate that into the device before it's sort of done, it's frozen. So we are still able to tweak it. So we want to make sure we get that from you guys. Also looking for collaborators for the larger scale clinical trials. So if there's any, obviously there's lots and lots of health professionals from the regional community. So please come and chat with me if you're really interested in being involved in the clinical trial going forward. And also in terms of planning for the implementation, really love to hear from you all around, what would work within the community if we were to actually have these devices manufactured. Should it sit at the Aboriginal Medical Services? Should it sit within, should it be sent home? What would be the best deployment of a device like this? Because that may affect how the device is produced and created, the kind of functionality it might have.